Welcome everybody, good afternoon to you. It's my pleasure to be here with my two colleagues and friends, P.Pereira from Portugal and F.Hassel from Germany, on the invitation of the Medtronic team for this webinar concerning the perioperative management patient care in spinal surgery. And we will focus our talks on ERAS protocol, enhanced recovery after surgery, and of course, minimally invasive spine surgery techniques. So I will begin directly with ERAS program, and don't hesitate to use the question and answer Q&A system on the lower part of your screen if you have questions for us. So I'm neurosurgeon in France, in Paris. Maybe you probably heard these terms of fast-track surgery, accelerated recovery after surgery, rapid recovery, or enhanced recovery after surgery. The concept was defined by Enrique Late 20 years ago. It concerned at the beginning the colonic surgery, but now it spread to all subtypes of the surgical field. And Kellett conceptualized that he made the hypothesis that a combination of elementary, unimodal, evidence-based care interventions were able to enhance recovery of patients with decrease the need for hospitalization, convalescence time, and morbidity. It's very important to know, if when we speak about ERAS, that this fast-track surgery has not been developed to reduce the length of stay. The first goal was to provide a pain-free and a risk-free surgery, and then at the end, maybe reduce the length of stay. So you heard a lot of appellation, a lot of terms, but I prefer enhanced recovery after surgery, and the acronym is ERAS. That's the term with speed notion, because the speed is not the most important in this concept. And the first step is to kill the dogma we heard since we are resident during our formation from our bosses and so and so. It's a non-exhaustive list of a lot of things we heard and we daily imagine in our practice that we say, we explain to our resident, to the young, we receive from the old, and a lot of those dogmas are not referred of real truth, surgical truth, but only by the habits and the use too. The bed rest is good until 2 days after surgery. We always drain. I always brace my patient after surgery. I give always morphine. So it's a lot of dogma. And if you want to switch your practice to ERAS, the first thing is to declare the death to all those dogma, and not only you as surgeon, but the anesthesiologist, the nurses, the director of the institution. This is not an easy task. That's to change the habits is not very easy. That's the first Coca-Cola in France in the 1950s, and it was not easy to switch from the Côte du Rhône wine to Coca-Cola. 7 pillars to the enhanced recovery after surgery: patient education, protocol management, create protocol, create pathway for the patient. And one of the most important things is to have a multidisciplinary approach. Is to create an ERAS pathway in your institution is not a surgical problem, it's a problem of all the stakeholders, and that's probably the most important and the most difficult things to create, this education of caregivers. Of course, we have to dedicate a lot of time to create protocols to control the stress and to manage the pain in the perioperative period for the early realimentation, early mobilization, secured discharge with scores, and of course, permanent evaluation. And that's the 7 important parts to create an ERAS environment in your institution. And of course, there are a lot of tricks. We will talk a long time in the 2 second topics on MIST techniques. It's perfectly convenient with ERAS, and a lot of tips and tricks. We don't use anymore old fasting. We organize standing patient. We walking with their files directly in the OR, not on the wheeling beds. The patients are no pajama paresis, and we use ES to follow the patient after their short discharge. It's a lot of tips and tricks you can implement in your daily practice to improve the ERAS in your institution. And when speaking about ERAS, it's always, we will always see those 3 steps. It's the journey of the patient: pre-hospitalization, hospitalization, post-hospitalization. And you will see in every papers concerning ERAS, those kind of steps, information, for example, here, information of patient, MIST techniques, multimodal opioid sparing pain control. It's always the same topics. And you have a lot of huge amount of papers in all subspecialties with very convincing results concerning the first published result in colorectal surgery. They proved that it was the complication risk was divided by 2, and I don't know a medicament, a drug, or a retractor or a screw who can provide such an improvement with the organizational improvement to create the ERAS pathway in your hospital. The same kind of result concerning orthopedic arthroplasty. They reduce mortality at 2 years with very convincing way, and years after year, there are convincing results in each surgeries, and especially for elderly patients, but for every kind of surgeries. I will go shortly to the ERAS Society because it's a transversal society which was created a few years ago. They had their congress last year. This year it's cancelled, of course. But last year it was only 20 minutes about spine. But now the ERAS Society is focused on spine. I will say some words about it. The first paper published in the spine area was German by Pfleger, and they show a convincing result with preoperative patient education. Tom Wainwright, my friend and co-author for the guidelines, published a checklist of to implement ERAS in institution. It was one of the big first paper concerning our field, and more and more, year after year, you see young team giving us experiences and more clinical results. Michael Wang from Miami, Florida, published 2 convincing paper, but it's clinical series, but he have very interesting results without complication and with good effect on the length of stay. And of course, in each of those papers, you can see checklist with the concerning stakeholder to improve to implement the ERAS. That's very important. It's not, once again, it's not the problem of the surgeon. You can't switch to ERAS by yourself. You have to be convinced, you have to convince all the team, and that's not the easier part. You have even ERAS paper concerning pediatric scoliosis, and with a very nice effect in terms of patient satisfaction, diminution or same complication, and diminution of length of stay. And if you consider the last published paper, you see a peak of paper, those 2 last year, and a lot of team worldwide concerning ERAS in spine. And you will see, and it's the rationale of this webinar, that ERAS share a lot of concept with the minimally invasive surgery. I won't go on the MAST because the next speaker will refer to it, but if you consider the important point of the minimally invasive spine surgery, respect the muscles, less blood loss, better initial pain control, earlier rehab, shorter hospitalization, is exactly the same rationale as ERAS, so it's a good parallelism in the 2 concepts. And we published with the team of Geneva last year in Neurosurgical Focus a paper comparing these 2 concepts, and it's exactly the same argument. So, to provide a successful surgery, there are a lot of unknown factors, not only the question of the good indication and the perfect techniques of the surgeon, and it's on this unknown factor that we can improve, speaking about ERAS. And once again, that's an example of paper published to introduce a program of ERAS in your team, because once again, it's not the problem of the sole surgeon. I will go quickly on this slide. It was in one of our papers last year in European Spine Journal, and you will see the journey of the patient before the hospitalization, the modern fasting, arriving at the morning of the surgery. No patient arrived the day before in my institution. Walking patient to the OR, avoiding of morphinics, no drain, no brace, physio the same day, and very early discharge. And we keep contact with the patient once he's home with a mobile application. It's not mandatory, it's just an example to make a fast track and improvement of the management. We published recently the result concerning lumbar fusion and anterior or posterior surgery and cervical fusion, with a very good effect on the length of stay, on the economical part, and on the clinical part, even a better result in the ERAS group comparing with the classical group in our experience. So the complication was perfectly acceptable. You have this same result in other team with a diminution of the decrease of the use of the of the opioids, and it's very important in this period. Exactly the same argument for ambulatory surgery, because according to me, ambulatory is just a part of the ERAS. So ERAS Society, I go to the guidelines just to finish my talk, published a lot of guidelines in each subfields of surgery: colonic surgery, gynecologic, thoracic, cardiac, and it's always a good, important milestone in our specialties. It was not the case for the spine, so we organized a group of development group for the guidelines with orthopedic and neurospine and neurosurgeon worldwide, anesthesiologist, of course, dedicated ERAS nurses, an epidemiologist, physiotherapist, and of course, guys from the ERAS Society. And we defined 22 topics, and we made, of course, the review of the literature. It's just submitted to the Spine Journal this week, so I will go quickly because I'm not supposed to show you very important results. But more or less, you see this always these 3 steps: pre, per, and post surgery, with a lot of topics, and I won't be able to detail us, but what I want to show you that the topics concerning the surgeon are very few. Of course, we are concerned by the patient rehabilitation, the cessation of smoking, and of course, but what's concerned purely the surgery, it's very small part, and all the ERAS relies with all the specialists, all the stakeholders, and the patient itself, and that's very important to understand this. If we organize, if we try to publish guidelines, we have to follow some rules of evidence-based medicine, and we all know that the paper of very high level RCTs specifically are very rare in spine surgery, and it was the difficulty for our team to find very high level of proof papers to create reliable guidelines, and especially for the surgical topic, miss or not miss, or open or navigated or not. There are clinical series, very convincing, but there are no, of course, RCTs, very few, and sometimes the proof is not very high, but we're able to provide a recommendation nevertheless. I will not detail all our recommendation. I hope that this paper will be accepted very soon, but once again, guidelines are important, but evidence-based medicine is not only our practice. Our practice is done by, of course, the paper we read, the high-level paper, but our own experience and the comparison of the patient values. And it's very important to create a mix of those concepts to try to improve patient. For me, and I will conclude very soon, ERAS there is a buzz around ERAS, not only in spine surgery, but in every surgery. I'm sure that in very few years, we will not talk anymore about ERAS. It will be our daily way to do surgery. For me, patients arriving the same day, like we do a lot of ambulatory surgery, they receive a QR code and have a mobile app to be followed at home. We don't drain any more patients. We try to use less opioid as possible. We have dedicated nurses on call, and it's just the way we do surgery now. And I'm sure that in a few years, ERAS will not be a concept, it will be our daily practice. And that's the most important message of my talk. Because in conclusion, ERAS make us to have a reflection on our daily practice as surgeon, as anesthesiologist, as nurses, as director of institution. And the problem is not to guide the surgeon, is to guide all the stakeholders, and it's not easy sometimes to change the habit. And that's, I wish you to have a good success if you want to implement this new concept in your daily practice. Thank you.
There is a question for you, Bertrand, if you go to the question and answers.
Yeah, hi, do you think that putting a drain overnight will delay discharge next day after ICDF? No, I don't think so. In the literature, you will see that the drainage is a huge problem. If you type on PubMed drain and spine surgery, you will have very conflicting results. In my institution, we try to make a homogenic attitude, but we had a very bad experience 2 years ago with a suffocating hematoma, and we decided to drain all the patients. And never, we are doing a lot of ambulatory surgery, but we never do ambulatory surgery with the neck. And we put a little drain, but it's not for the patient, to be honest. It's for the eventually lawyer expert we will have. We have to study this one. But if you decide to drain the patient, you can remove it and let it go at the first day. It's not a big deal. It's perfectly possible. But a lot of papers show that there is no need to drain cervical surgery.
Okay, so shall I go on? And then if we have more time at the end, we can go back to these or other questions. So I also would like to thank the Medtronic team for inviting me to this webinar. It's a pleasure also being with my colleagues like Bertrand and Frank. Always a pleasure to share initiatives and training. I'm coming from Porto and in Portugal, or not coming. I'm still here, but I'm a neurospine surgeon coming from the Hospital São João and the University of Porto. So my topic is like showing you that ERAS and minimal invasive techniques are like a perfect match. And I will try to convince you of this during the last 50 minutes. Every single presentation on minimal invasive spine surgery always have some slide like this one, just stressing and emphasizing that we are not talking about the size of the skin incision, but we want to minimize soft tissue retraction and destruction. And doing that, we hope to avoid postoperative pictures like this when after a lot of like simple decompression, quite often we see postoperative scar such as this one, and the midline structures have been completely destroyed. And doing that, minimizing this damage to the paraspinal muscle, we hope to improve postoperative rehabilitation. And this is what Bertrand, Dr. B.Debono was speaking about. So doing that, we want to improve the postoperative, to enhance the rehabilitation and have a faster recovery. One of the problems of looking at this and searching in the literature is that we can call this acronym, the MIST or MIST surgery, can apply to a lot of different techniques, from totally percutaneous needle techniques to percutaneous screws and stabilization, endoscopic technique, microscopic techniques, tubular retractors, and other things. And this is the key issue when we look at the literature. For instance, this is a recent systematic review with a meta-analysis related to lumbar stenosis. But for instance, when you look at the table on the right side, they have compared two completely different things that are not comparable at all. For instance, you see some of those papers compared microsurgical decompression to full endoscopic, also to interspinous device, to muscle splitting laminectomy. So these are completely different surgical techniques. So when we try to do a systematic review. And if you, I don't know how it's possible to perform a meta-analysis based on this, because we are comparing apples with oranges. With minimal invasive spine surgery in lumbar spine, typically we are talking about surgery to decompress pathology that is inside the spinal canal, being it spinal stenosis or disc herniation. We also use it for extraspinal pathologies like foraminal or extraforaminal disc herniations to decompress the spinal canal. And then we have a lot of different surgical techniques and procedures that can be used on a minimally invasive way or a less invasive way. So I will concentrate more on this. The other problem that we have is that how do we evaluate the outcomes? And this is a reason why we see so different conclusions from different papers. So when we are talking about outcomes, what are we talking about? Are we talking about improvement of neurology? Are we talking about improvement of pain, of the probes, of the blood loss, length of stay, rate of complications, rate of fusion, the return to work, costs? So this is a these are completely different questions. And also you can just design your study to look for the data that you want to look at. So I just remember a presentation from Professor Richard Fessler from Rush University in Chicago, saying that if you are organizing a race, a 100 miles race between 100 Ferraris and 100 Fiat Punto, if your outcome is how many patients, how many cars reached the end of the race, you conclude that there is no difference. You conclude there is no difference between a Ferrari and a Fiat Punto. So this is quite important. So your conclusion is depending on how you define and how you design your study. So talking about missed decompression, typically what we do is just using a tube or a retractor, just go from one side, go to the contralateral side, and decompress bilaterally the spinal canal. And at the end, you have pictures like this one, but also you can, when you look at your anatomy, you see that you preserve the midline structures. So the supraspinal ligament is preserved here, and the attachment of the multifids are preserved as well. So anyhow, this, you don't expect so much difference in the postoperative between using a tube or using a micro retractor if you are not doing a 10-centimeter incision for a decompression. But still, if you look at data from, this is a systematic review with a meta-analysis comparing open versus minimally invasive decompression for stenosis that has been published in Spine. And still, even not being so different surgeries, you still see that minimal invasive decompression compares is at least equal or compares favorably to classic open techniques. But as I said before, I'd like to concentrate particularly in missed lumbar fusion. And when you look at these pictures of a postoperative or intraoperative picture of open PLE4 TLIF, and you look at the same picture in a minimally invasive TLIF, probably you don't need you seem that you don't need a lot of data to prove that what is on the right side seems to be different from what is on the left side. And this study, the classical study of published of the parachutes, always comes to my mind. If you really need to do an RCT or to prove something that when you look at that, it seems quite logical. But still, I think it's important to draw data and to try to find some results. And one of the problems also when you look at the literature is most of the studies are done in a single center. So the results are very dependent on the experience of the surgeon. So that's why this study was designed. This is a study promoted by Medtronic like 10 years ago, including patients from different sites, 19 sites coming from 14 countries. And there is a study related to postoperative outcomes after minimal invasive sleeve or TLIF for 1 or 2 level degenerative pathologies. The primary endpoint here was the time to the first ambulation and the surgery recovery day. And this paper, the results have been published in the literature, the early outcome and the late outcome papers that you can see here. And just briefly, that study included 252 patients, most of them with stenosis, like 70% of the patients had stenosis and more than half had spondylolisthesis. Most of the patients were operated on 1 level, and we have about 16% of the patients were operated on 2 levels. This is the first results, like the mean time for surgery was like 2 hours for 1 level, 3 hours for 2 levels. An important result here is estimated blood loss that was typically below 200 milliliters, particularly on 1 level, and just 1 patient required a blood transfusion. The primary outcome was the mean time to the first ambulation was 1.3 days, and the mean time to surgery recovery day was 3.2 days. This surgery recovery day was something defined in the protocol to try to accommodate different practices, because as you know, in different countries and different regions, some patients tend to go out very quickly, some stay in the hospital for more days for different reasons, and the surgery recovery day was defined as the first day where the patient has no IV catheters, is fully ambulatory with no assistance, and does not require nursing care, specialized nursing care. So this is the ancillary outcomes. Where, as you see, this is quite similar to what we typically see after fusion or after TLIF. There is a significant decrease, well above the minimum clinically important difference for back pain, for leg pain here, for the ODI scores coming from the first postoperative evaluation to the 1 year follow-up. This is the EK5D, different parts or different parameters of the EK5D and the index, and again for the EQ-VAS. So we also looked at the adverse events. The rate of adverse events, the total rate was 15%, but as you can see here, it includes very common things like nausea and some seroma and vertigo and vomiting. So when you look specifically at the adverse events related to minimal invasive approach, we just have 3 adverse events and 1 serious adverse event. During the 1 year follow-up, there were 7 patients who needed a revision surgery, 4 at the adjacent level and 3 at the same level. When you compare these results with the literature, this is a meta-analysis published in JNF Spine 4 years ago, when they compare minimal invasive posterior fusion with open posterior fusion, and the rate of reoperation was the same, but the rate of complications was 40% less in MIS, and the medical complication rate was 60% less in in minimal invasive fusions. This is also another study related to adjacent segment complications, where they also compared missed T-leaf or PLIF with open T-leaf and PLIF. And as you can see here, when you see the rate of when you look at the single level, the adjacent segment complications were about 1/3, and the rate of complications in and the adjacent segment disease was like the difference was almost reduced to almost 1/2. We also looked at ancillary data. We have our population is more and more aged and more tends to be more and more obese. We also look at this data. We divided the patients in 3 age groups and 3 weight groups. And also, as you can see from here, the time to first ambulation was not different in age and weight, age groups and weight classes, but still there was a significant, statistically significant linear relation between the more aged patients and more obese patients for time for post-surgical recovery day. But when you look at the PROMs, the ODI, the VAS, all of them improved equally, and there was no difference between subgroups. Same for VASBEC and for EQ5D. This is also similar to what you can find in the literature regarding obese patients. This is also a systematic review published 2 years ago in European Spine Journal, where the intraoperative blood loss is like less than 1/3 in the minimum invasive T-leaf for obese patients comparing to open, and the dural tear complication is about 1/4, and the length of stay was 1.5 days shorter than in open surgery. So now we have a lot of, these are the results for, these were the results for minimal invasive T-leaf and PLIF. Now we have more and more, it's more and more common to have different minimal invasive approaches coming from lateral, transpsoas, anterior to psoas. And that's also the reason why Medtronic promoted another study that is called MASTERS D2, including more patients, including patients from different regions of the world. So this wants to be like a real world study and not very specialized centers, included patients also from Latin America and Asia Pacific. And it included patients who underwent anterolateral approaches as well to the posterior ones. It included PLIF, T-leaf, mid-leaf, A-leaf, D-leaf, and O-leaf. And the patients, the enrollment was finished 1 year ago. And just as a teaser, you can, if you assist the virtual annual meeting of Eurospine, there will be 2 papers that will be presented there orally related to these studies, so you can see these results at first hand. So to conclude, I think that implementing ERAS protocols together with MAST techniques really can improve and enhance outcomes and patient satisfaction, and then MAST should be a key issue in ERAS protocols. Thank you very much. So there is one question here, the question coming from Dr. Amar Sebali. We are faced more and more to operate very old patients, more than 80 years old. We try to avoid the surgery in this age group. Should we encourage to use MIS in these patients? If yes, what about osteoporotic complications, screw pull-out, and case subsidence? Thank you. So my question, this is the reality all over the world, and this is going to be more and more the reality. So we try to avoid surgery on patients independently if they don't need, so conservative care must be exhausted before proposing surgery, but we operate more and more patients over 80 years old. But as you could see from these results, the results from MASTERS-D are not specifically for patients over 80 years old, but as you see, the patients who are older, typically the length of stay is a little bit longer, but at least in my practice, these are one or the most, between the most satisfied patients. So the happier patients that I have tend to be the oldest one, because also probably the expectations are not as much as big as the other ones. Screw pull out, as you know, we have different techniques to reduce the screw pull out, like that we don't have time to speak here, but we can use cement augmentation and other techniques. In particularly bad bone quality, sometimes I use them, but the other techniques that I tend to use in very osteoporotic patients are cortical screws, because they tend to have a very big fixation. There's another question here from Dr. Katri. Are there results on myths and errors for trauma spine surgery? Maybe Bertrand, Dr. Bertrand could answer that, if you please.
Yeah. Of course, ERAS at the beginning was conceptualized for elective surgery, because we are supposed to prepare and educate the patient before the hospitalization and the surgery to improve the pathway and his journey through this moment of his life, or her life. But what is very stunning, I experienced that in my institution. When you implement ERAS, there is an ERAS effect even for the procedures and surgeries we are not on the ERAS area. I explain myself. I recently moved to Paris, but when I was to Toulouse and when we published the most of those papers concerning ERAS on lumbar fusion, we just see that other surgery and even brain surgery, because I'm a neurosurgeon and we performed a brain surgery, there was a decrease of the length of stay even for those procedures, not targeted ERAS, because we didn't use any more drain. We shortened the length of stay. We decreased. We accelerated the first stand up from the bed, the physio in the same day of the surgery. Even for brain surgery, even for long construct, we were not in the ERAS procedure, and there is an efficiency. But of course, for now, the publication if you type ERAS and spine surgery in PubMed, you won't have for trauma. For me, of course, there is a lot of publication on percutaneous surgery for trauma, and it was invented at the beginning for trauma, especially for the screw mistargeting.
Thank you, Bertrand. Yes, ready for the last talk. So we move from the beautiful city of Porto, which is my favorite city in Portugal, to the beautiful city in Germany, Freiburg, which is next to the beautiful country of France. Okay, so we have really a nice setup here about the minimal invasive spine surgery in this webinar. Thanks to two great talks, and I hope I can give you some interesting outcomes of my department here. So the experience and sharing of the result in MAST techniques. If you look for the minimal invasive spine surgery and you do an internet Google research, like in our times, everybody does, you have about 9.5 million results, okay? In only less than 1 second, only minimal invasive spine surgery. This is quite impressive. So actually, the last decade has seen an evolution of MIS techniques with new technological developments. And to be honest, this is thought to decrease postoperative pain, allow a quicker recovery, and by limiting our soft tissue retraction and dissection. So the advantages in microscopy and tissue retractors, as well as we get some specialized instruments from Medtronic, for example, these enable the surgeons to perform procedures through small incisions, which was really great. We had these mini open techniques with tubes like quadrant, etc., percutaneous screws and hybrid techniques. So to really focus on the minimal invasive spine techniques, the goals of the minimally invasive approach are, as with the open approach, to adequately decompress the involved neural elements and to stabilize the motion segment, as well as to realign the spinal column, and according to the needs of every individual patient. So this is just a definition in spine 4 years ago about the MIS. So MIS procedure is one that, by virtue of the extended means of surgical technique, results in less collateral tissue damage, results in measurable decrease in morbidity and more rapid functional recovery than traditional exposures, without differentiation in the intended surgical goal. Just in one, the changes over the last decade, if you look at the same study in the spine, instrumented spine procedures in the US performed with minimal invasive exposure was 10 years ago, 1 out of 6. 6 years in 2016, so 4 years ago, it was already 1 out of 3. And by this year, we have the new numbers will be about every second instrumented spine procedure. So here are some older mini-open in degen spine, some older data, one from the European Spine Journal, 28 minimal invasive versus 31 open approach. We see less changes in multifidus muscle, less post-op back pain and functional disability after the surgery, and we have less CK levels, less fatty degeneration, and a better outcome overall. And here another study from the European Spine Journal about lumbar spinal fusion. 2 groups randomized, mini open. They had significant lower blood loss, faster recovery, shorter hospital stay, and they required a lower analgesic drugs, to be honest. So what are the problems in MIS? To be honest, we are all great surgeons, but to do it in minimal invasive doesn't mean that you have any anatomical landmarks. So the field of view is very small. Visualization might be a problem. We have no anatomical landmarks. We have an increased radiation. We have only 2D imaging and prolonging of the surgery time. Some of the colleagues work with 2 C-arms, which gives you radiation like hell. So what are the problems in integrating these MAST techniques in your daily routine? Actually, we have fear of new technologies in our departments. Is this a safe technique? What about my workflow? Is it a stable system? Can I trust the new technologies? Then I have to argue with the hospital administration about the higher cost. We have a learning curve, longer surgery time. We have to change our practice. So surgeons hate it all the time. We meet with refusal in the team and our nice colleagues from around the corner. They say, oh, these crazy guys from over there. And we have only practical and easy cases in the beginning. So I show you an easy case from our hospitals. It's a 66-year-old male with low back pain, no radiculopathy. He was in conservative treatment since years, and he has an osteochondrosis L4-5 with spondyloarthritis. These are the pictures. Really easy, straightforward case. Here's some video from my clinic, from my hospital. As you see, we're using a navigation system. We're using the O-arm, doing a 3D a picture of it, and then we start with it with the mini open approach. Dilate it here, position of the retractor. You see the reference frame on the right side, and here just put in a picture, X-ray, to show you how we decompress and prepare the disc space L4-5. Then we extract the disc, measure the cage size, and position the cage. Everything is done with navigation, with the help of navigation, and then we position the cage. After we've done that, we can place the pedicle screws percutaneously with navigation, and this is really great because you see what you do on the screen live in action, and you're going to be safe not to place the screw into the spinal canal, as you can see on this screen. Then after we done it, we fixed the rod. That was a second case. Final result, easy, straightforward. Some of you, the colleagues asked for some literature of spinal fractures, traumatic cases, percutaneous instrumentation in fractures. This is the trauma journal, a German trauma journal from 2009 already. Surgery time in MAST technique is shorter, 42 versus 91 minutes. Blood loss, significant difference, 15 mils versus 720 mils. And radiation time, which is quite identical. With getting together with navigation, you really save the radiation. Hospital stay shorter. You see the Germans, they like to stay at a hospital because they get good food and don't have to pay for it because the hospital or the insurance company will pay it. Percutaneous instrumentation versus open fracture, another one from a German journal. Lumbar fractures, they showed that surgery time, radiation time, and pedicle screw accuracy was statistically no different from open to percutaneous. Blood loss was significantly less in the minimal invasive approach, and open surgery leads to permanent damage of muscles. We all know this now. Here, another example of a traumatic L1 fracture with posterior wall fragment, high-grade spinal stenosis, and osteoporotic bone. Some years ago, our solution was percutaneous instrumentation T12 to L1 with longitude system, navigation, and 3D imaging. We used fenestrated screws, saved cement application, reposition of posterior wall with a special repo set of the longitude 1, and do a kyphoplasty. Here you see some pictures of it here with putting in the screws and cement them and open everything up, and then we place the cement in after we dilated the balloon. And this is the final result, which only with some small skin incision, patient is doing great, even she has an osteoporosis. Let's look further on. Percutaneous instrumentation versus open in infection. Here a study, 45 patients with a spondylolisthesis, percutaneous instrumentation 20 and 25 open. The surgery time was in the PERC group was shorter. The blood loss was significantly less. You see 89 mils versus 340, and the MAST group had lower VHS. After 2 years follow-up, no recurrent infection in the MAST group. Here another case from our department, 19-year-old male with multiple diseases, low back pain since 2 months, no neurological deficits, no trauma, white blood cell count 6,000 CRP 78, and a CREA of 1.4. These were the pictures, and we did a percutaneous instrumentations right away, and he could walk straight away. Another thing, tumor. What about tumor cases in minimal invasive? 76-year-old male with lower back pain since 1 year with a colon carcinoma, liver metastasis, and L3 metastasis with radiation and chemotherapy. Here are the pictures, MRI. We did a percutaneous screwing, and he could walk away out of the hospital without any bracing. So what about interesting cases about deformity cases? We have lumbar scoliosis with a listhesis of L5S1 and instability, stenosis, both sides, osteochondrosis, multi-level. MAST in deformity cases, what do we need here, to be honest? We have to open up the facet joints, do a posterior release, long construct for good reduction correction, decompress L5S1, both sides, cage L5S1 because of instability and spondylitis, L5, good fusion mass, may be a good choice for a hybrid technique. The result was we did an open approach because it was straightforward and the surgery time was lower in these cases. But we know today we have to look at the sagittal balance, and because we have some French colleague here, I have to put this slide on. And we have modern MIS techniques in deformity include hybrid surgery with MRS interbody fusion, open posterior fusion, and percutaneous posterior instrumentation with MIS osteotomies and anterior column realignment techniques. Like lateral and anterior approaches, the techniques that continue to progress are the use of percutaneous instrumentation in thoracic spine and ilium, and expansion of retroctor approaches into thoracic spine with expandable implants. They place through smaller approach corridors, expand to improve the spinal alignment and provide indirect decompression. So the big question is now when to use minimal invasive techniques. Look at the literature, no guidelines. Maybe we will have some guidelines when Bertrand is finished with his study, and I'm really interested about the ERAS program. There is a tendency actually in the literature that percutaneous technique is in fracture treatment, mini open in 1 or 2 level fusion, but actually it's an individual decision is necessary. So look in our department, in our practice, what we do a percutaneous instrumentation in unstable traumatic or osteoporotic VCFs in combination with kyphoplasty or a mini open anterior approach where we perform a corpectomy and vertebral body replacement. If we have a solitary and stable metastasis in a palliative situation, if you have an infection of the disc in combination with a mini open in intradural abscess and mini open in single and B-level instability with stenosis on one side, we go for MAST techniques. So a few words and then I'm finished. How did we manage to start with the MAST technique? You have to inform the team, convince people, relieve the fear from new technique, hand over the responsibility, delegate, motivate, plan, and do it every day, and define the operational sequences, and you have to trust the techniques. Hospitations are great. Look for tricks of other colleagues. You don't have to reinvent everything for yourself. You have to have the willingness to learn new things. You have to optimize the sequences and get rid of the redundant steps and list up the benefits. And most of all, integrate with the anesthesia team. If you are working against them, it's not good for you and your results. So the benefits of MAST in daily routine are you profit from all benefits of the integrated technologies. For example, navigation, you have a higher efficiency, less problems in setup. You have better results, profit in complex cases, reduce complications. You have less revisions, lower costs. And this really helps experienced surgeons to become better. So I don't know why it doesn't stop. Maybe it stopped because of Medtronic stopped me. Thank you, everybody. All right. Any questions?
2 questions.
Would you fuse L4-5 symptomatic disc and leave L5 black disc alone as you did it in the first case? Yes, of course, I would. Otherwise, I wouldn't have done it, to be honest. What is your practice of advising a brace after surgery? Any evidence-based? No. To be honest, no. Actually, today we slow some of the patients down, and it's not an evidence here, but I like not to give them a full speed ahead, and I think it won't be good for my results. But it's not. There's no evidence in it.
If I can add a comment, there is no evidence in the literature concerning it. For the future guidelines of ERAS that you mentioned, we choose to focus it on lumbar fusion because the spine surgery is wide and huge. So we begin by one of the most practiced surgeries. So it's lumbar fusion, and the topic surgery and the MIS surgery, the evidence are poor, but the recommendation will be strong. And that's the rule of the guidelines. You have to follow the guidelines of guidelines and to look at the level of the published paper. The proof are low, but our recommendation to use MIS techniques will be strong. But it's rely on very medium level of proof, evidence papers. And a last thing, you mentioned something very important for all those techniques. Navigation, perioperative CT like O-arm or MIS retractor you have to do it as soon as possible, because if you do it only in complex or specific cases, not only you, but all your team will be inefficient, and you will take a long time. The colleagues will say, okay, it don't work, and it's very difficult. But if you use it in a daily mode, it will be a great success for all. And once again, it's not a problem for the surgeon, but for all the team to be keen and to be okay with all those techniques.
Perfect. Perfect. If there are no questions, I conclude. So we heard a great webinar, great talk from Bertrand, actually from Greece, not from Paris right now. And he's smiling all the time because he has the best weather of us. And he was talking about a great talk about the enhanced recovery concept connected to the MAST in spine and to speed up our recovery for our patients. Paulo, he was talking about improving the outcomes in minimal invasive spine surgery, and he showed us the latest data, how to elevate the outcomes and to evaluate our outcomes. Great talk. And I just tried to show you some setup of the MAST techniques and the enabling technologies into spinal practice and how I perform it in our department. Actually, thank you all for your time. Thank you, Medtronic, for that great webinar. Thank you all the colleagues, and I'm looking really for the ERA spine guidelines coming soon.
So
have a nice evening, everybody. Thank you.
Bye-bye.
Thank you. Thank you very much. Bye-bye.